Hello and welcome everyone. My name is Renee Garrett and we're kicking off season 2 for Brainstorms Functional Neurorehab for SLPs. I'm your speech therapy PD podcast host. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for zero point 0.1 ASHA CEU. Dr. Leanne Togher is being funded by the National Medical Health and Research Council and is the author of Conversability, which may be commercialized in the future. Dr. Togher is the chair of the International Brain Injury Association, chair of Brain Injury Australia, and international board member for the ASHA Journals Board. Dr. Rietdijk is an author of Conversability, which may be commercialized in the future, and she has no relevant non-financial relationships to disclose. Kate Smith has no financial relationships to disclose, and she is a current member of the speechBITE Advisory Committee. Renee Garrett is the owner and founder of BrainBridge Connect and is the host of Brainstorms Functional Neurorehab for SLPs. I receive financial compensation from Speech Therapy PD for the podcast and other educational webinars on Speech Therapy PD. I'm also an adjunct instructor for both James Madison University and Old Dominion University. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Questions can be written in the chat box or the Q&A and will be answered throughout and hopefully at the end of the presentation, depending on the number of questions. Now, without further ado, let's welcome our guest, Dr. Leanne Togher, PhD, FSPA, FASSBI. Professor Leanne Togher is a full professor at the University of Sydney, Australia, an NHMRC Professorial Research Fellow and Investigator Grant Leadership Level 3. Professor Togher holds a PhD in speech pathology and is internationally recognized with more than 250 journal articles. Professor Togher has led the development of communication treatments for people with brain injury and their families, our carers, and community agencies, including TBI Express, TBI ConneCT, and the Social Brain Toolkit. She is the director of the evidence-based practice website called speechBITE. Professor Togher is the incoming chair for the International Brain Injury Association and chair of Brain Injury Australia. Dr. Rachael Rietdijk is a certified practicing speech pathologist and lecturer at the University of Sydney with interest in acquired brain injury, communication partner training, and digital health. Her PhD research produced a new evidence-based intervention for people with traumatic brain injury called TBI ConneCT. Dr. Rietdijk worked with the project for the Social Brain Toolkit, including Interactability, the first free evidence-based online program about how to communicate successfully with people who have brain injuries. This program has reached over 1,500 people from over 25 countries. Dr. Rietdijk continues to collaborate as part of research teams of the Communication Connect NHMRC Ideas Grant and the Communication for Safe Care NDIS Information, Linkages, and Capacity Building Grant. Her research is internationally recognized with 24 publications and 3 book chapters. She's currently working with research students to continue to investigate the use of digital health for communication partner training. And finally, Kate Smith, MSPA, CPSP, is a speech-language pathologist who has been working in the area of evidence-based practice for 2 decades. Kate is a member of the speechBITE Advisory Committee at the University of Sydney and worked on the development of speechBITE with Professor Leanne Togher for more than a decade. Kate is currently undertaking her PhD in which she is applying a user-centered approach to co-design a new digital resource that provides research evidence for SLPs. And thank you all for being here with us. We are so grateful to work with you and chat with you today. And I'm so grateful to have you all here.
Thanks for having us. Thanks for the invitation, Renee. It's
Yes.
just lovely to be here.
Yeah, no, and it's morning for you and evening for me, so you can tell that my fluency is a little bit not where it should be, so excuse all the bobbles.
No worries, it'll be fine.
Yeah. So let's jump right in. I want to talk about how the Social Brain Toolkit came to be, touching on things like where did this idea come from? What was the research kind of behind it?
So I might kick us off. Our work has really been going now for well over a decade, probably more like 15 years actually. So it's like one of those things. There's no overnight successes in building new training programs that are, and we're very happy with it, how it's turned out. It started with way back, I think, when I was doing my own PhD, and I identified that communication partners were having a lot of difficulty in knowing what to do when they were interacting with people with severe traumatic brain injury. And it was really the problems of knowing what to do with all of those kind of conversational behaviors that make you feel a bit awkward, like if someone's talking too much, or they're not talking anymore, they're not able to generate topics anymore, if they're very apathetic, or if they're going off the topic and very tangential and a bit confused. I really noticed in my own study that mothers, for example, when they were talking to their sons with a brain injury, were having all sorts of issues knowing what to do. And I compared them to the same mothers talking to their sons who did not have a brain injury. And so there were these marked differences between these two identical, that I'd given them the same thing to talk about. So it wasn't the topics were different. It was just this, the mothers were doing different things with their brain injured sons. And mostly sons, I say, because it's mostly people with males that have brain injuries. And we identified that some of what the mums were doing was not helping. So asking their sons a whole lot of questions that they already knew the answer to, like, what did we do yesterday? And the mum knew the answer to that question. She was trying to help her son remember. And these sort of behaviours were done out of, I think, from a point of love. They were really trying to help their sons and trying to help them get better. But they were not giving them the same linguistic opportunity that they were giving their sons without a brain injury. They would ask their sons without a brain injury, what did you do over the weekend? Oh, you went out with Claire. Oh, that's fantastic. What did you do? So they were like real conversations. Whereas with the brain injured son, they'd say, what did we do yesterday? And they'd say, oh, we went to the beach. And they'd go, good job. Yeah, we went to the beach. That's right. That's really good. So that was just one of the behaviors, asking testing questions. So after my PhD, I embarked upon a postdoctoral research career, and I firstly actually did some training with the police, because I'd also studied how police talk with people with brain injury, and they'd also had difficulty knowing what to do when talking to someone who had a brain injury, which
Sure.
they weren't getting training in that. So we did a randomized controlled trial and found that we could help police learn new strategies and have more successful conversations with people with brain injury. And maybe a lot of it was to do with the way they asked their questions, and also how they spoke to the people with brain injury, talking to them more as adults rather than kind of children, which is what I was seeing. They were sort of being very polite and nice, but it wasn't exactly how you or I would like to have a conversation with an adult. Once we'd done that, I felt brave enough to get into family communication. I was quite nervous about doing that because it's a fairly intimate thing, right? Sort of dealing with family interactions. And so, but anyway, I felt like we needed to do something. So we got some funding from the NHMRC, which is like the NIH in the United States. It's our federal funding body. And we ran a trial and developed this program called TBI Express. And TBI Express was the first training program that we built that really it was designed to help the person with brain injury and their family member in all the sessions. And it had both individual and group components. And it was really probably more focused on the family member than it was on the person with brain injury. So we were really trying to help family members think about communication, which we don't normally do, right? It's so automatic. You don't even think about it. So it was kind of bringing to consciousness what they were saying and how were they saying it, and what impact did that have on their loved one with a brain injury. And teaching, and they all had their own individual goals, because everybody's communication is affected in a different way after a brain injury. But nonetheless, they came together and we did small groups and individual treatments for a 10-week period. And it led to much better conversations, essentially. We did quite a lot of outcome measures and had independent assessors look at the outcomes. But the bottom line was that family members and friends and whoever came to the training as the partner who was being trained learned strategies that then supported the person with brain injury to have just more enjoyable conversations. They were less effortful, they were more interesting, they were more enjoyable, like they were smiling, they were enjoying these conversations by the end. So from there, we thought, this is great. The only problem was the treatment takes 35 hours into TBI Express, and of course it's too long. So it was fine for a research project, but we identified that we probably need to try and shorten it up a bit. And we also identified from our qualitative findings that people were traveling quite a long way to get to where our treatment programs were being held. And so this was long before COVID and before Zoom, actually. It was Skype. And so we thought, yeah, remember Skype?
I do, yeah.
Who uses Skype now? I don't know. But anyway, so that was where Rachel's PhD came from. And I might hand over to Rachel because she can talk to her study, which that was TBI ConneCT. So I might hand over to you, Rachel.
Yeah, thanks, Leanne, for that lead-in. So picking up on what Leanne mentioned, we wanted to still take the core content of TBI Express, but package it in a format that was more accessible to families who might not live near a clinician providing communication partner training and who might not have the time available to commit to that 35-hour program. So we modified TBI Express to develop this new version, TBI ConneCT, that was just delivered to the person with TBI and their communication partner as sort of an individual dyad. So we took out that group component that we had in TBI Express, and we also looked at delivering it over telehealth. So as Leanne mentioned, it was Skype at the time. This was sort of 2017 through to 2019 that we ran this study. So what we found from that study was that, what we were trying to find out was whether the people or the families who received the telehealth version of the training had similar outcomes to the people who received the in-person version of TBI ConneCT. And the good news was that we did find similar outcomes. So in terms of people's improvements in the quality of their conversations and what they reported about their communication skills, we found that there was positive outcomes for both the people who received in-person TBI ConneCT, as did the people who received telehealth TBI ConneCT. So then I guess our next step was we wanted to think a little bit bigger and sort of expand our focus to think about how we could scale up these ideas of communication partner training more broadly, which led us to the Social Brain Toolkit project. So with the Social Brain Toolkit, we were trying to think about, I guess, broadening our focus beyond TBI as one of the issues. So we were looking at acquired brain injury. And we also were starting to think about the potential of using online and digital tools to help us deliver communication partner training in some different ways. So in terms of the Social Brain Toolkit, the broad goal is for people with ABI to have better interactions socially. So whether that be with their mum, with their close family members, whether it's with more extended, the interactions with sort of extended family or even community members, coming back to Leanne's mention of people like police or other community members, but also thinking about those interactions people with ABI might be having in online spaces, so on Facebook or other forms of social media. So the Social Brain Toolkit is actually a suite of 3 resources. So the first one being Conversability, which is a communication partner training program that's really built on those foundational principles that have carried forward from TBI Express and TBI ConneCT. So it still involves interactions with the clinician in the same way as we had in our previous versions of communication partner training, but also includes some new functionalities. So we have self-guided modules for the person with ABI and their communication partner to complete together that can then be reviewed by their clinician. And that includes the capacity for the dyad to work together to record a conversation that is actually uploaded to the platform, and their clinician can provide feedback on that conversation. So in terms of where that one is up to, we're still doing some further research on that, but we're also starting to use it in our student clinic at the University of Sydney. And we're starting to look at ways of how we can expand the availability of that particular resource to clinicians in Australia and hopefully internationally in the future. The second component of the Social Brain Toolkit is Interactability, and that is a short self-guided online course for any type of communication partner who interacts with someone with an acquired brain injury. So we're really aiming with that particular tool to upskill a range of communication partners in quite a short period of time. So that is, in terms of the online course, it involves a range of different case studies. So we've got videos of people with aphasia, people with dysarthria, as well as people with cognitive communication disorders. And the aim really is for people to quickly upskill in some strategies that they could use to have interactions with that range of different types of people with acquired brain injury. Completing the course takes around 2 hours in total, and if people complete everything and complete a quiz at the end, they are able to access a certificate. So we found that quite a useful kind of motivator for some of the people who are completing that training. Then the third and final element I'll mention about the Social Brain Toolkit is another short self-guided online course called Social Ability, which is targeted more towards the person with acquired brain injury themselves, towards the goal of having safe and successful interactions online on social media. So again, there's a number of different modules that people can work through, covering things such as what is social media, how can I use social media, how can I stay safe, and who can I connect with. And again, it's around 2 hours to complete. The person with ABI can either complete it on their own or potentially with the support of a family member or clinician. So in terms of the process of developing these 3 tools, it's been a process, and what we've tried, our aim along the way has really been to partner with people with ABI and their family members and their clinicians through a process of co-design. So we've built sort of initial prototypes of the tools and then collected feedback that then we've been able to use to iteratively develop each version of these tools to where they're up to today. So yeah, that's a bit of a roundup of what clinicians can find in our Social Brain Toolkit.
Well, and I think one of the things that I found so fascinating is, of course, as you all know, one of my mentors knows Dr. Tor, and well, let's be honest, a lot of people know who Dr. Tor is if they've worked in the TBI or ABI space, because the research that you've published has been really groundbreaking and so helpful for a lot of us in our clinical practice. But thinking about my own experience as a caregiver long before I was an SLP, I just feel like this is so groundbreaking and pivotal for training communication partners. One of the things I try to instill in my students is that we are the communication experts. The people that are on the other side of our tables or our spaces that we're treating in don't come in typically with this knowledge of communication and how to modify ways that we communicate with people who've experienced a traumatic brain injury or an acquired brain injury like in stroke. And this is so helpful for students to be able to access and see early on in their career so that they're able to provide resources and tools that they may not get in their graduate programs or their PhD programs. They're getting a lot of theory and a lot of research driven ideas, but they're not always getting practical ideas and tools and tips that they can take away and employ tomorrow. So I think that for me, that was the part that I was so interested in and the reasons for having you all come on, because I don't know of any place else in the world that they have this program that you can have access to across the continuum for caregivers, for the patients themselves, for clinicians, for students. Was that the goal initially?
I think with TBI Express and TBI ConneCT, I think our goal was trying to help clinicians, giving them the building blocks to use. Because you're right, it's not something, we're pretty used to working on communication goals for the person with brain injury. And you sort of assess a person's brain injury communication, and you identify their strengths and weaknesses, and you work on goal development with them. But it's a whole other ball game working with people who haven't had a brain injury. And that's essentially what you're doing most of the time with partners. And they all come to training with a wide range of experience or lack thereof about what makes a good conversation. So I think initially it was, how do we give clinicians the tools that they can then, and some structure so that they can look at a recording. I mean, that was one of our first barriers. You look at a recording of someone with a person with brain injury and their partner, and what do you do with that? How do you assess that? How do you figure out what to work on? Is there something to work on? These are all those sort of foundational questions. So I think our assessments that we do and the sorts of rating scales that we've been very fortunate to come across and develop with very generous people like Dr. Aura Kagan from Canada. Like, she gave us her scales that she developed for aphasia, because there was literally nothing for TBI. Nothing. There were no, I looked and looked, there was no scale for us to rate the behavior of the partner and what they were doing. And so we had to adapt it, because aphasia is different to the kinds of social communication skills we see after TBI. And we had to do all the psychometric assessment of those. And we've actually just released another paper about that, about the feasibility of using the adapted Kagan scales as an assessment tool. And I'm happy to share the Kagan scales with your audience, because it's out there and available, and we're happy to share it. But it was really, how do we assess these things? How do we develop goals? And then how do we treat? What do we do? And what do we treat and how do we do? I'm in internal debt to Dr. Mark Ilvasaker, who some of your audience may know, an absolutely brilliant. He was a speech language pathologist. He was also a philosophy graduate. So he did philosophy, and he knew a lot about educational psychology, and he actually worked a lot with children with TBI. A lot of the concepts that we're using come out of his work with parents talking to their kids, and preschoolers even. And so I'm often asked, I mean, the programs we've developed are for adults with TBI or ABI now, but the concepts came from the pediatric literature. So there's still that bit of work out there that someone could develop this for children and adolescents with TBI. I'm hoping someone does that one day, picks up what we're doing, and that we have another version of this training. So I think we'd sort of used a lot of his concepts, and he talked about thinking about the person's identity and what's their post TBI identity, and how do we acknowledge that they're competent adults, and how do we make sure people talk to them as if they're competent adults. And so there's some fairly high level concepts that underpin the training. It's not just about social skills training. In fact, he didn't like the term social skills training at all. He talked about having relevant, meaningful, salient interactions for the person with brain injury, and being really aware of what the environment around them is doing, whether it's hindering or whether it's helping. And so we developed a lot of these concepts in TBI ConneCT, I think probably more than TBI Express. We started using metaphors to help people understand what we were talking about. So rather than talking about taking turns in conversation, we talked about passing the ball. And you've got to make sure you pass the ball, and you don't want to pass a really big ball that's too big to catch. So you don't want to have too much information, and you don't want to throw a whole lot of balls at the one time, because they're really hard to catch. So people that helped with the learning, because we're sort of teaching people how to relearn having conversations, which is I think it's been a real shift for me over the past decade, really, to think about how do I do that whilst preserving the interaction and the relationship, because you don't want to mess with that either. And you don't want the partners to feel guilty about what they're doing, or that, that they're doing something wrong. It's about reframing and making positive goals so that they can have better conversations with their family member, which personally, Renee, I've learned how to have better conversations with my own kids. Like they're in their early 20s now. And so in developing these things, it's something we can all do. You don't have to be talking to someone with a brain injury. It's
Right.
How do you have more equal conversations? How do you make sure the person has the opportunity to express their opinions and their feelings, and to tell you the stories about what's happening in their life, and how do you support that? And a lot of it's about being enthusiastic, smiling, taking interest, giving them time. Giving time is probably one of the top strategies we teach nearly everybody. Let the person have a bit of time to think about their response, which after a brain injury, people really, really need that if they've got information processing speed problems. And then I think the Social Brain Toolkit, where did that come from? It was, well, we need to get this word out there beyond speech pathologists and treating clinicians and people with brain injury and their family members. When people go out into the world after a brain injury, they're interacting with all sorts of people. They're interacting with their support workers, they're interacting with other hospital staff, other health professionals, other student health professionals. They're dealing with people in the community when they go to the local shopping centre. So how can we develop an attractive, accessible training program that anybody could do? So when we developed Interactability, the whole goal behind that was making it so that it was, and we co-designed it with people with lived experience and other stakeholders, so that, and we changed it because the readability was too high. We had to change some of the vocabulary so that if you're a support worker and you've got no graduate education, you might only have grade 8 reading level or grade 10 reading level. So how do we make this training accessible to those folks? And how do you make it accessible to the kitchen staff working in the hospital? So we've got captioning on this program. We've modified the text quite a bit. We've got lots of really lovely videos where people with lived experience and their partners are talking about what's a brain injury like for me, what helps me, what strategies would help me if you were talking to me. So that personalised approach, I think, is really important. And so the program has been picked up around the world, particularly in the US. So we've had a couple of the big rehab hospitals across the US, big consortium, who've made this training part of their credentialing process for all their new, we would call them enrolled nurses. I don't know, they're kind of they're not quite to nurse, they're not fully trained nurses yet, but they're developing nursing skills. So, and any new staff that come on, they get them to do this interactability course. They've got to produce their certificate that they've done it, so that they can show that they've done some training about how to communicate with someone with a communication disorder, whether it's aphasia. And we don't use the words of aphasia specifically because we know people don't always know what that means. We do talk about it in the training a bit, but it's people who've lost their language, people who have difficulty getting their speech out, and people who have social communication problems. So we've got these separate modules that people can do, and they can pick and choose, and each module takes about 20 minutes. So we called it snackable learning. It's about as long as a snack. And so you can do one module in a tea break and come back to, and the website, we ask that people log into this, but we can keep track of where the website keeps track of where they're up to, so they can go in and out of the training, and it keeps up to date with what they've done so far. So I think it was about socializing this idea that everybody who interacts with someone with a communication disability has a responsibility and can generally learn skills about how to improve those interactions and feel confident. We notice people, just especially students, they really lack confidence. They walk in, they're talking to someone who maybe can't speak back to them at all, and they really don't know what to do. So being able to have some strategies about what is AAC, how do you communicate someone who can't talk at all, what can I do as the partner? So we've tried to cover a lot of those. We've tried to cover a lot of those concepts in the shortest possible time so that people are able to do this training. And we certainly get all our speech pathology students to do the training at the University of Sydney. It's sort of like the first little taster. And I think it, you know, if you've not talked to someone, we get very used to talking to people with communication disability. But if you haven't done that before, I mean, I can remember the first time I talked to somebody who did not talk back to me. And it was like, oh, okay, what am I going to do now? Like it's confronting, and it can be, unless you've learned some skills and strategies, it's really hard to do. So I think interactability was born out of that need to at least get an accessible training program out there so that people might have something to look at before they might have found out they're going into a brain injury unit next week on a placement. How do I prepare? Well, you can do interactability, and that's gonna help. So it's good for speech pathology students, but it's good for all, like our physio students, our OT students, our nurses, our doctors. I think we've set it up so that it's giving them some simple strategies that hopefully they remember when they go into those first interactions and put them into practice. Yeah. And I think the Social Brain Toolkit also was born out of the work of Melissa Brunner, who is one of our team members, Dr. Melissa Brunner. She did her whole PhD looking at how do people with brain injury access social media after their brain injury. And so she did a lot of qualitative work looking at how do family members manage a person's social media. And quite often they just cut them off because they don't want them to get in trouble. They're vulnerable. They don't want them to sort of embarrass themselves in the social media arena. The clinicians were gatekeepers as well. Clinicians often said, oh, you better not let them on Facebook. You better not let them go on their social media training, their social media accounts. And the people with brain injury were kind of frustrated because they've lost their social networks. And here there's this whole social network out there online and they can't get to that either. So from Liz's, I think, groundbreaking PhD work, and she's published all of that, it was, what can we do? How do we work on this issue? And the first step of that, she's got a whole program of work happening, but the first step was to build a training program that, once again, accessible, easy to follow, has good readability, captioning, videos. It's actually fun to do. It's got a lot of nice interactive tasks. It's not your typical online training program, I don't think. And it has 4 modules in it. And once again, you can pick and choose. You can go in and out. But the goal of that was really to help people think about social media, maybe do the training with their family member. That's something they can do together, and then come up with some strategies about how can they re-access their social media safely. And so it's really another way of improve. I think our whole program of work, Renee, is about social connection, because we know people with brain injury lose all of that. By 6 months, on average, they have 1 friend left after a severe TBI. So it's really trying to think, how can we build those bridges? How can we make those people around them feel confident? Can we train friends early on and say, look, these are things you can do this is what's happened. Let's understand what's happened. Let's understand how communication is affected after a brain injury. It's not that your friends just suddenly become a very strange person. It's that they've had a brain injury, and we know this is what happens after a brain injury. They're going to continue to improve. And in the meantime, these are things you can do to help. And friends want to know what to do to help.
Yeah.
But
family does too. Because honestly, yeah. And you're thinking about, especially with families but also friends, there's a sense of loss, not only for the patient, but there's a lot of overwhelming aspects for caregivers in general about the diagnosis, what comes next, what can I expect? And then on top of that, layering this communication piece. So again, I think this is why for me, I just found this incredibly helpful, the interaction, because it's more real, it's more realistic. It gives us this real picture of how do we employ these things that we learn in school, but we may not know how to put it into practice. It's hard sometimes with all the things that we learn to pull it out and then implement it later on. And so for me, this was really pivotal in not only training patients and their caregivers, but also now in the space of having students. As I taught TBI last semester, and then this semester I'm teaching a language disorders class. It's mostly aphasia and dementia based. So I'm having my students go through and look at this, and I'm
Oh,
not
fantastic.
assigning it per se, but maybe later I might assign
Yeah,
it.
we'll see how they go. But I think it's just nice for students, if particularly if they're really looking for something extra and they just want to understand this whole, it's very complex. We know communication after brain injury is unbelievably complex, and it's hard for a student to have a distilled set of strategies that they can immediately put into place when they're talking with their first patient or their second patient. And so we've tried to create something that would address that issue. When you start to talk about the difference between TBI Express, which we had 35 hours of training, that's where we really can get down into the weeds and look at the complexities of interaction. So we've tried to address both ends of the spectrum, if you like. But I think interactability is kind of just that little stepping stone in for people to start to think about all the different ways brain injury can be affected after communication can be affected after a brain injury. Yeah.
Well,
I think sorry, you go, Renee.
Oh no, I was going to say I'm super excited. I've put it in the chat a couple of times now to
Beautiful.
direct people to the website, because
Yeah.
the questions have been based on the components and not necessarily the connection of the components are part of the Social Brain Toolkit. So
Yeah, and just to reiterate, interactability and social ability are free. Anyone can do them. You just get a login, you go in, off you go. So we've wanted, my goal with all the training programs that our team have developed is to make them either free or as low cost as possible. And all of us get no money out of even the published manuals that we've published. The royalties go back to the Australasian Society for the Study of Brain Impairment. So we don't make money out of this. It's really trying to make these things as freely available as possible. Yeah.
well, and I think that's a good place to kind of jump to SpeechBITE and connect the two of those, because again, SpeechBITE for me is it's I actually learned about that from Dr. Stacey Raymer. She's a huge fan of it. She talks about it quite a bit. To me, it parallels the Cochrane database as far as the reviews, the accessibility, but making sure that we know as clinicians how to discern research. So I would just really like to know a little bit more about, again, how that came to be and the components behind it.
Well, I might start off that conversation and then I might hand over to Kate Smith. But just as a general background introduction, there have been groups here in Australia from other health professionals who have developed databases of evidence-based treatment research. So there was one developed for physiotherapists called Pedro. There was one that's since been archived, but it was called OT Seeker, and it was developed for occupational therapists. I personally was on the founding committee of another one that was called speechBITE, and speechBITE, which is now NeuroBITE. NeuroBITE was is a repository of treatment research related to all the behavioural problems that can happen after a brain injury. So it's a big searchable database. And anyway, I was on that committee for quite a while. That was led by Professor Robin Tate, who was here at the University of Sydney. And Kate Smith worked with us on that, actually, back in the late 1990s, early 2000s. And it occurred to me that we did not have a searchable, indexed, curated repository of treatment research for speech pathologists. And so I approached Speech Pathology Australia, and they gave us the initial tranche of funding to look at developing a resource for speech pathologists. So that all happened back in 2005. So 20 years later, we are still going, and Speech Pathology Australia is still supporting us. And we also get support from the Royal College of Speech Language Therapists in the UK. And the speechBITE is also free, and it's set up so that if you're a clinician seeing a particular kind of patient, it covers the entire scope of speech pathology, so birth till death, basically, and it covers the whole scope of practice. So language disorders, speech disorders, voice, fluency, and swallowing disorders, and literacy. And it also covers all the different diagnoses you could possibly think of that we see as speech pathologists. And so we do an auto search every month of all the relevant databases, and we have a set of criteria. It has to be about speech language pathology treatment. It has to be a peer-reviewed paper. It has to have data in it. So we've got a set of criteria, and we upload the latest research every month. We also have a newsletter that you can subscribe to. So we have about 11,000 people that we send the newsletter out to each month. And we choose the top 5 papers of the month that people can access. And we try to choose papers that are open access. So we have this, it's essentially a database, a searchable database. So if you want to, for example, seeing someone with a traumatic brain injury, they're an adult, and you're wanting to find out what cognitive communication treatments are available, you can go through, there's a set of drop-down boxes, and you can do a very specific search and find what are the latest papers, or what are all the papers, really, since we started speechBITE 20 years ago. And the papers are, when you do a search, you get it's a different kind of set of responses. We always put the systematic reviews first, the most recent systematic reviews. They get listed first, and then we list the randomized controlled trial papers that have happened, then the non-randomized controlled trials, single subject designs and case series, and then practice guidelines. So if you've only got 2 minutes to look up what's the latest research that's happening in a particular area, we try and give you the latest, most up-to-date summary up the top, because you get a systematic review that's usually got the latest. This is the state of the art of this particular area of practice. And so speechBITE has been an essential part of our speech pathology training. Our students all learn to use it. It was included in our competency-based standards and our professional standards here in Australia. So our students all get very familiar with speechBITE because it's something they can quickly look up when they're on their clinical placements, to look up what is the latest research I need to know about to help me build whatever treatment I'm going to be doing with my patient that I'm going to see in 10 minutes. So it was set up as a clinical tool for speech pathologists, and it was and is designed to save time. If you look up do a Medline search, you might end up with 2,000 papers that come back, and then you go, oh my God, I haven't got time for 2,000 papers. I can't do this. So you give up. Whereas speechBITE, we've done all that searching for you. We've searched Medline. We've done all of the big databases, and we've kind of, once again, distilled just those papers that are relevant to speech pathology practice, and they're just about treatment. So it's all treatment papers. Did you want to add anything, Kate? I feel like I've talked along too much. So Kate's been along this journey, and she was the project manager for speechBITE for a very long time. And I think, as a way of introducing Kate, part of Kate's research now that she's happily doing in her PhD with us at Sydney Uni is going that next step further. And it's one thing to get a treatment paper and be able to download it and read it, but then what do you do with it? And how do we actually make our clinical decisions? And speechBITE doesn't help you with that. That's still in the clinician's head, what they're going to do next. And I think what Kate's trying to do is, how do we summarize this data even further to help clinicians make decisions about their treatment? So Kate, I'll hand over to you, because
Thanks, Leanne. Thanks. As Leanne said, I've worked on speechBITE for more than a decade on the development of that. And during that time, what I noticed was, when I was looking for the research for that database, was the research landscape changed so much in 10 years. There's so much more research, over that time. And also the digital landscape has changed so much. Just generally now we've got so many different places that we can find information, like on social media, websites, so many different databases. So over that time, I became very curious about how we meet the sort of clinical information needs of speech pathologists in this new digital generation. And from that, I had my own burning question, which became my PhD, which was to take a deep dive and look at how we address some of the barriers that we've seen really quoted so many times over the years about evidence-based practice, which is not having enough time, as Leanne referred to, just to be able to kind of pick up the research, read it, work out what to do, and then really kind of access as well. Like we're so used to having information at our fingertips in life, just generally, but can we meet our needs? Can speech pathologists meet their needs every day of the week when we're practicing? So with that in mind, I started my PhD a few years ago now and to do a deep dive into the clinical information needs of speech pathologists. So what I wanted to do, rather than thinking, well, how can we just develop a next generation of tool, is to look at the needs that speech pathologists have every day in clinical practice, and how do they find information when and where they need it, when they actually need it at the point of need. So that led me to develop a PhD that was based in 3 phases, and I'm looking at the need to speech pathologists through a user-centered lens. So I want to know all about their experiences of looking for research, what they're looking for in resources that are online, and what are the main features that they're looking for. So as part of that, one component of that work is what I'm doing at the moment. So that's a survey, just looking broadly at what tools speech pathologists are looking for and using internationally, and also some interviews and focus groups I'm going to be running. So that will be in Australia and internationally as well, to get the experiences of clinicians who are on the ground at the call face when they're looking for information. How can they find information quickly to get the answers to the clinical questions that we all have every day? So one main piece of that is looking at evidence summaries. So if we're looking for information to answer clinical questions, sometimes we want that in a more distilled format, something that's really easy to pick up. Now, I'm drawing on my research from stuff that's been done in medicine too, where they've looked at what doctors do and what sort of information the doctors use at point of care. So at that point, we're interacting with clients, would that be in the community or for us in schools, or would that be in a hospital setting? So looking at things like the evidence summaries, for example, what sort of formats do speech pathologists want for information? So if they're looking for things quickly, how brief and concise do they need that information? And how can we make that information have a lot of usefulness or utility in practice? Like, for example, what do we value? Do we need things like clinical bottom lines? Do we want key takeaway messages? Do we want recommendations and evidence summaries? And looking at other factors. So we mentioned before the Pedro scale, which is one scale we've been using a lot to indicate to clinicians the quality of evidence. But my research is going to look at what type of quality indicators do clinicians really want. So they're picking up a research summary, an evidence summary. It's got to be really useful so they can pick it up and, like you're saying, Renee, to discern it really quickly. Is this a quality piece of evidence? Is this the best evidence I've got in this particular area? And what's going to work for clinicians really quickly in that clinical context? And then looking at other factors like the type of information they want in an evidence summary. Is it only really about treatment? Do they want some information on dose and frequency of intervention? So breaking that down. So that's one part of my research will be working with clinicians to work that out. And then the next part will be distilling that into kind of a list of requirements, saying this is what we want our evidence tools to look like, and then developing a prototype that I'll then develop co-design with clinicians. And then when we get the first digital version of that, then we'll be doing some simulation testing with clinicians to look at the usability. So this will be the first research of this type in our profession that's looking specifically at clinical information needs. And I'm hoping it'll be kind of the foundation. So when we can build the next generation of tools, that's going to have some research legs to it, I'm hoping. But meanwhile, I'm still enjoying working with the SpeechBITE team a lot to see how that tool is still growing very strong all these years later, which is great. Yeah.
I just put the link up in the chat to your survey, Kate, just if anyone was interested. We're super keen to hear from American speech language pathologists about what would help you in your clinical practice, in your clinical decision making. And so it only takes, I think, 10 or 15 minutes to do, but it's, yeah, we're looking for some input from American speech pathologists. And obviously whatever we build, speechBITE is internationally available. It's used across many countries, including the USA. And we're keen that when we build this prototype, which we will, that we would be able to trial it in the US as well. So yeah, we're looking for, what do people want? What do you need? What's going to help you? So
yeah, and I'm creating some show notes as well. So anything that I put that in there, but anything that you want to send over, a lot of people have asked about the rating scales.
Oh yeah.
So if you want to share the link to that, I can put that in there as well.
Do that.
But Kate, wow, that's such a light project. How do you have time?
Well, I think that actually I'm really passionate about it. Since I've been working on speechBITE I've actually started working on NeuroBITE, which is, as Leanne mentioned, was the predecessor with Robin Tate. So this has been my existence now for 20 years. So I'm really looking around and seeing all this amazing stuff happening in the digital space and thinking, well, how can we kind of merge what we're doing with that? So I'm loving it. Yeah.
Yeah, that's amazing. And thank you for your work. I'm excited about it. And I probably will be taking your survey. It may not be tonight, but
I think we've got it open till the end of the month. So yeah,
time.
We'd love to hear from you.
Yeah, of course. And I'll see if I can put that out for colleagues as well that are working.
That'd be brilliant, actually, if people could share. We're really, just putting the link for speechBITE in as well, just in case people have not heard of that.
Yeah, well, and I think, again, going back to, and this is just a conversation I've had with a couple of colleagues recently about how to discern research. A lot of times, I think clinicians who haven't been well trained in looking at the components of a study. I mean, I had a whole research methods class, and then there was another research class that we had to do, a statistics class that we had to do that were solely focused on research statistics. But I think a lot of people take the class, they kind of brain dump it if they're not in that space. And what happens next is you get in the field and you really don't know how to look at a research question and see if the methodology and the resources and the study itself is focused on answering the original question. A lot of people will pull up research and just go, oh, well, this looks good because it was a pretty big study, but they're not looking at the components and really analyzing if this is a valid project or if it was just something that got picked up. For example, there was a recent study that came out, and I know this isn't about dysphagia, but about dysphagia and saying that thickened liquids was indeed better. But if you look at the components of the study and what the original research question was, they were very disconnected. And of course, we know that that's not true for every patient, that thickened isn't always better. And we worked so hard to dispel that old myth. And now we have people coming out with research that's saying, oh, yes, go thicken all the liquids. So I think it's.
Yeah, I think judging the methodological quality of a paper, I agree with you. Like I don't believe I was really, I mean, I was trained a million years ago, but it was,
No.
I don't know that we did a lot about methodological quality back then. And so that's why we rate the methodological quality of all our group comparison studies on speechBITE. So I think we've got about 80% of them rated at the moment. That's a constant thing to keep that up to date. But that Pedro score, it's a score out of 10. And if they get a 6 and above, we have moderate confidence that that paper has good methodological quality and that there aren't biases in that paper that would help lead us to question the findings. So we've tried to do the Pedro ratings as a way of helping clinicians at least get an idea of, is this paper, if it gets 2 out of 10, it's got a lot of problems. And so the findings may be flawed. And so you can't just take what they've written at face value. And some people, like we've had papers come in and they've say this is a randomized controlled trial. And when we look at the method, it's not. So it gets scored down on a Pedro scale because they didn't randomize and they don't tick all those boxes. So we do need to be critical, and it's hard to know how. We are about to put up a Pedro training program that'll be in the next few months on SpeechBITE, so that if you're really interested, you can go and do it. Once again, it'll be free. You can learn about how to rate the methodological quality of a group comparison paper. And NeuroBite has that sort of training as well, also for single subject experimental designs, because they're also very hard to read through and go, is this done well or not? So we've got this scale called the Robin T scale, which is like the Pedro scale. It gives us a score of the methodological quality of that single subject design paper. And yeah, so there's training available on NeuroBite as well, which people can go and do. So I think we've tried to help clinicians in terms of understanding some of these issues and having quick access to scores to help them choose which papers they might want to read more carefully. That they can have confidence with. Yeah.
Yeah. Well, and we have a couple of minutes left for people who might have questions. So I'd like to open up the floor for questions other than the ones that have already been in the chat that I tried to answer some, and thank you, Dr. Rietdijk, for also helping answer some of those questions. So does anyone have questions? Please place them in the chat or the Q&A. Well, while we're waiting to see if someone has questions, I do have a question. When you were developing, we'll go back to the Social Brain Toolkit, were you looking at the complexities of caregivers and the sort of that grief process that people go through and trying to accept this diagnosis and accept these new challenges that they experience with their loved ones, while also navigating things like health insurance and next level of care and who's going to be staying out of work and helping take care of this person and get them to their appointments? Were any of those components part of what you all considered when you were developing this training?
Do you want to answer that one, Rach?
Yeah, I agree. That's a lot of complex factors that we need to think about when we're working with communication partners. So I think one of the issues you mentioned was that grief process, and that's something we've thought about quite a bit in terms of when is the right timing to work with a communication partner. And I guess with our more intensive programs like TBI Express, TBI ConneCT, and Conversability, we've really would probably see those programs as more suitable for, say, at least 6 months after an injury, once people have sort of returned back home, they've found their new normal. But every family is so different as well in terms of when they're really ready to take on board this training, because as Leanne mentioned, it's quite sensitive work that we're doing when we're doing that training, say with a partner or with a parent, and really focusing in on that dynamic. And I guess to bring in the interactability piece, I guess that's one of the things we were thinking about with interactability, is that because it is that self-guided resource, it could be a link that people are provided even in the very early stages of an injury as something that they could come back to when they're ready. And because it is free, it addresses that accessibility component in terms of insurance and funding for services as well. And we have sort of flagged that for people in interactability in the welcome section, that judge for yourself whether this training is, well, this course is, if it's the right timing for you to proceed. If it's not, that's okay. It's accessible for you to come back to at any time down the track if you want to dip in and out of it. So yeah, I think every family's journey is so different. So we have tried to think about the flexibility of accommodating that as part of the Social Brain Toolkit.
Wow. Wow. You all are doing great stuff. And again, I'm just so grateful for you agreeing not only to come on, but adjust your schedules. For those of you who are listening, you may not be aware we had daylight savings time, and Australia also has their own daylight saving time that just occurred last weekend, right?
All right.
And
Nice Sunday.
so, yeah, we had accounted for a 16-hour time difference that is no longer a 16-hour time difference. So I appreciate you all adjusting and pivoting with me and helping me figure out all of those pieces and parts. But more importantly, I just thank you for being so willing to share your research, share the resources, keeping up with them being accessible to us as well in the US. And so I just really think that the work you're doing is pivotal and helpful for everyone. So, from the bottom of my heart, Dr. Tor, Dr. Rietdijk, and future Dr. Smith,
Yeah. Yeah.
I just appreciate you coming on. So, if there's any last thing that you'd like to leave us with, we would be grateful.
I think probably just to summarize, we have a lot of resources online that are free. So if people look up our ABI Communication Lab website, we've got links to quite a lot of information about, like, for clinicians and for families. TBI Connect, Rachael put on a lot of information that's all free. And we have a YouTube channel. So if people want to look at any of the videos that we've made, some of the training videos, we've got some really evidence-based demonstrations of good versus bad conversations, if you like, and they're all professionally done. They've been much looked at and used. But if people aren't familiar with those, they're welcome to look at them. They're all on YouTube. They're all free. And if anyone has any questions or wants to follow up on anything, please contact us directly. I sort of have emails every day from all over the world, so I'm very happy to answer questions or have a chat with somebody or whatever. So we're very open to being collaborative, and we just want to get the word out there and help people change their practice.
Well, again, thank you so much for being with us. Thank you again, Dr. Rietdijk, Dr. Tor, and future Dr. Smith. And we look forward to seeing you again and hopefully working with you more in the future.
Yeah, we look forward to that too. Thank you so much, Renee. It's been lovely to be here.
Thanks,
Yeah.
Renee.
Thank you, Renee.
Have a great day.
Thank you.